introduction to welcome Dr. Chibu Okoli to the call. Dr. Chibu Okoli has many degrees, and she's currently the Deputy Country Director for JPIGO Nigeria and an affiliate of Johns Hopkins University, Baltimore, USA. She is the Project Director for the RICOM3 project. So she's our big mommy and our big sister. And then she's focused on reducing, RICOM3 project is focused on reducing the indirect causes of maternal mortality in Lagos State and the Federal Capital Territory. And it's funded by the MSD for Mothers. She is a public health specialist with extensive experience in strategic development and implementation of maternal and child health and quality of care programs. She has published extensively in peer-reviewed journals, both academic papers and policy documents, and consulted actively on maternal and child health issues, HIV/AIDS, management of chronic diseases, non-communicable diseases, and women health issues. Dr. Okoli, we welcome you to the call. Our programs lead and quality lead is not on the call because she had some family emergency to duly attend to, and I know that she's with us right now on the call, hoping that all goes well wherever she is. So she's Dr. Kendra Njoku, and her qualifications are on the screen. I'm sure we all know her, or a lot of us know her. Thank you, Eni. So Dr. Okoli, I'm going to hand over to you now, ma'am, so that you can take the floor. Welcome, and we are honored to have you. Thank you so much for coming. Thank you. Over to you.
Okay, thank you very much, Dr. Aima. I hope you can hear me.
Yes, I can. I believe we all can. Yeah.
Okay, I hope we all can as well. I'm so happy to be here this afternoon. My name is simply Ugo. I know my full name is Chibu Ugo, but everybody calls me Ugo. I'm actually very happy to be presenting today, but my presentation is actually not from me. It's on behalf of all the health facilities, the 10 health facilities in Lagos and the 10 health facilities in FCT that we are supporting. And all the healthcare workers, from their MDs to the quality improvement teams, to the records officers, to the lab people that have actually worked on this project from November 2018. It seems very far away, but you guys have achieved a lot. So I'm presenting on your behalf so that you can actually see what you have achieved over the last 2 years, especially in the last 1 year when we started implementation. But I do also recognize that there are other people that log on to these ECHO sessions every month that are not part of the 20 health facilities. So I welcome them, and I hope that this opportunity we'll use this opportunity to actually really give them a brief and an overview of the project. So whenever they join on the ECHO sessions, they can actually understand the background and context of RICOM3 project. So I will kick off. I know I'll have time to acknowledge people at the end. So today, what we are going to do is to give you a brief overview of the RICOM3 project. Dr. Aima has already explained what RICOM3 means, reducing the indirect causes of maternal morbidity and mortality. And then we will go through expected results. When we started this project, we had expected results, and we will go through them and then also go through the key results we have achieved. And then after that, we will go through how did we do it? How did you, the healthcare workers that we are presenting to today, do it? And I hope today that even though you're working in different places, different locations, you begin to see how your contribution has actually added to what we are presenting today, and how you have helped to improve the quality of services that you're providing for women, especially around indirect causes and especially in the ANC units. And then we will go on to look at the challenges that we have actually encountered and look forward to when we actually scale up on this project. Next slide. So just to set the background, we know that our overall goal and aim is to actually reduce the maternal morbidity and mortality from indirect causes. And we know that what we have tried to do is to apply a woman-centered quality of care model to improve prevention, early detection, and management of these indirect causes, which is often associated with preeclampsia and eclampsia along the continuum of public and private maternal and health and reproductive health services. We focused largely on the ANC for quite a period of time before we moved on to the other touch points. And we know that these indirect causes that increase the risk of preeclampsia, eclampsia, and often premature cardiovascular disease are often high blood pressure, diabetes mellitus, obesity, and anemia. Those are the 4 areas that we are focusing on. There are other indirect causes, but these are the 4 areas we are focusing on. And we have been implementing, as you all know, where you are located now, in Lagos and the FCT, in 2 local governments in each of the states, in Lagos, Animosho and Ikorodu, in the FCT, Amak and Buhari, and we have implemented in 20 health facilities, 10 of them in Lagos, 10 of them in the Federal Capital Territory, a mixture of general hospitals, primary healthcare facilities, and private hospitals. And how have we done it with you all? Together, we've done this in 3 phases. Phase 1 was when we came out, you remember, in early 2019, we came out, we did an assessment of the risk factors and prevalence of these diseases within the community. And then we went on to the health facilities to actually do an audit. We used a tool to actually assess the readiness of the health facilities to actually provide quality services in this area. Also through that, we did observations in the ANC clinics. We also did some interviews with healthcare workers to assess their knowledge and confidence in providing services in this area. Then phase 2, we used the results, gathered people together, and then designed a quality of care model. And then phase 3, which started 2019, October to September this year, we then implemented the components of that model in all the 20 health facilities. So what were our expected results? We had 6 main results that we were working towards with you all in the health facilities. One was to actually carry out this prevalence assessment in the community with women of reproductive age. The second one was to be able to design the quality of care model that will be woman-centered because it's for women of reproductive age. And then the third one was to begin to improve gaps that we found, especially around screening for those clinical areas I talked about, hypertension, diabetes, anemia, and to ensure that we're screening all women for that, and then also beginning to control these indirect causes and begin to even document them, because what we found that was sometimes we do that, but we don't actually document. So that was our work with you all in the 20 health facilities. Then we also wanted to improve the self-care of women of reproductive age. So when we talk about the how, you will see how we onboarded, enrolled women from the health facilities onto a digital platform called Complete Health Platform, implemented by mDoc, one of our partners, and then supporting them to modify their lifestyles. And then the last but not the least, we also tried to cost what was existing and what we actually added to the implementation, because we didn't want to come and start from the scratch. We wanted to build on what was existing. And lastly, we also looked into how we can actually see where states can find funding to leverage on to actually sustain what we are doing. And our partner HSDF did this part of the project. So we will go straight into the results. Since this is an end of project dissemination, let's go straight to the news. So the first one was assessing the prevalence. What did we find? So we found out that nearly 1/3 of women in the FCT and Lagos, these women of reproductive age within the community, had stage 1 and 2 of hypertension, assessed along the lines of the American Heart Association guidelines. So women, a lot of them did not know, we are not aware that they actually had this hypertension. You could see that just a few of them, less than 1/3, were actually reporting, self-reporting that they had this high blood pressure. And we will go into the details of how we did this in the field. I'm just sharing the results now. Then number 2, the other slide. So we also tested people for, did blood tests for HbA1c, looking for diabetes or pre-diabetes in women, and then also PCV, looking for, HB, looking for women that had low HB levels or anemia. So you can see that 7.8% of women met the criteria for pre-diabetes, and then about 2.3% for diabetes. But again, the key thing was that less than 1/3 of these women were even aware of their status until they were tested that day and told. And there's not much difference between FCT and Lagos, as you can see. And then for anemia, we had huge proportions of women actually testing for, with low blood levels, as you can see in the graph next to the diabetes graph. The next chart. So the next chart, we looked at what risk factors, and out of all these women, how many of them had 1 to 2 risk factors, 1 risk factor, 0 risk factor, or 1 to 3. The main issue was that a lot of women actually had 3 to 5 risk factors. When you look at those gray bars, those that had 63%, 57%, 60%, a lot of women had 3 to 5 risk factors, actually across Lagos and FCT, within those local governments that we were doing the survey. Okay, if we move on to the next chart. So in terms of summary, the high-level findings were that women actually had limited awareness of these risk factors of indirect causes. This might not be surprising to most of you that are practicing. And then the prevalence of high blood pressure was high, obesity high, anemia, and then diabetes to a lesser extent. And you bear in mind that this was a young population of people aged 18 to 49, and only a small percentage of women with identified risk factors were even aware of their status. The facility assessment demonstrated a lot of quality gaps, poor adherence to best practice, low provider knowledge and confidence for managing these risk factors, and weak information systems, lack of guidelines in the facilities. And of course, we also did stakeholder interviews, which included women, and they actually gave us some ideas of how we can improve things in both states. If we move on to the next slide. So this might look complex, but I will take you through it. We sat down with stakeholders, women, the states, healthcare workers, and then devised a quality of care model, building on what you're already doing. The main things were that we decided that the essential components were that patient education and awareness, especially those that you do during ANC talks, and then early detection and screening, and making sure that you're documenting it, and then diagnosis, and of course, appropriate management and prompt referral. Referral is still an issue, which is something that we'll keep working on as we scale up. But then we felt that these components that I just listed now could actually be implemented in the community, going by outreach, mobile services, screening people in the community, detecting them early, and so on and so forth. But also within the health facilities where you're working. And we felt that it could be done at ANC, the family planning, postnatal care, and labor and delivery. And that's what we are aiming to do. We started with ANC, first of all, because we know that in the ANC, let's go back to the next slide. Yeah, in the ANC, we know that the women stay there longer, so that this is where we could actually have them. Then what did we add? We added things like setting up quality improvement teams, getting them to work using the PDSA cycle. We also got to build their capacity on site, have the ECHO sessions like monthly that we're having now to refresh their knowledge, and then also have learning reviews. We can move on. Next slide. So what sort of results were we getting? Because we were insisting on people screening every patient that came to ANC for blood pressure, and then ensuring that at least at first booking, that the women got their blood test done for hemoglobin levels, PCV, or also for random blood sugar, not just urinalysis. And these are the results. I'll just take it one by one. The first chart above shows the FCT, whilst the second chart shows Lagos State. And overall, judging from the low level where we started, we have made tremendous improvement from October to September this year. I can tell you that when we started, for instance, high blood pressure was documented and measured for 35% of the women attending. But by September, it went up to 70%. This is overall. For diabetes mellitus, it was 11%. By September, you guys had done a great job. It had gone up to 65%. Anemia was 20% at the start. By September this year, it had gone up to 60%. When we look at the two states, the differences are there. We can see that Lagos has actually done tremendously well and has actually kept their lines quite stable. FCT has also improved, but we have more room for improvement. And between then and now, we had almost 26,712 women registered for first ANC across the two states. Okay, if we move on to the next slide. So then we said, how do we also find out whether the women were actually receiving these services? The previous chart that I shared was us collecting data from you, the things that you documented in your facilities that you did. So we said, why don't we go out there, sample a couple of women attending ANC, and then ask them whether they were actually receiving these services. So we sampled 100 women from 10 facilities, 5 facilities in Lagos, 5 in FCT, 50 women in Lagos, 50 in FCT. And I'm happy, in terms of what the women said, they actually corroborated the improvements that you guys have already done. So the women, almost all of them were saying that, yes, their height was measured at least once, they had ultrasound, they were weighed at every visit, they had their blood pressure measured at every visit. But we still have room for improvement. A lot of them said they can't recollect their blood tests being done. And also the women were saying they can't also recollect their weight, them being told their weight when they were measured or being told their blood pressure. So it's a question of telling them their results. That's what we have to improve on as we scale up. Telling them their results. When some people might say, oh, they don't need to know, they don't want to know, but some of them want to know. So, and I think it's good practice to actually share their results with them and explain to them what that means. Okay, moving on to the next slide. So we also asked the women, what were their experience, in the ANC services. This survey was done June this year. So we asked them things like, were they explained the purpose of the medication given? Could they discuss things in private? Did they feel treated with respect? Did they feel treated in a friendly manner? And, very good results, as you can see there, from both states. But again, there is room for improvement, especially around felt treated with respect at all times, and then also felt treated in a friendly manner. And I'm sure that we can keep improving this. We share these results with individual health facilities so they know the areas that they need to improve on. Okay. So we also did some on-site capacity building using the Nigerian package of essential interventions for non-communicable diseases. We did it in 2 lots. We did it when we started November 2019 to January. We did another set in August this year where we moved to other touch points like the PNC and so on. And I'm happy to say that people received those trainings very well. And in both states, we could see an average knowledge gain of 10 to 15%. We trained over 450 health providers. I'm sure some of you listening to this are amongst those trained. If we move on to the next slide. Okay, I will hand back to Dr. Aima, or is it Dr. Naomi, who will take over now.
Thank you, Dr. Okoli. Dr. Naomi is going to take over and continue. She's standing in Dr. Kendra's place. Dr. Naomi is a senior project associate at mDoc, particularly on the RICOM3 project. Welcome, Dr. Naomi. Over to you.
Thank you very much, Dr. Aima, and thank you, Dr. Okoli, for that, introductions and everything. So I'll just be following up on what Dr. Okoli was saying earlier. So part of, improving provider knowledge, we started the Tele-ECHO sessions with the aim of creating a shared learning platform across patients' homes, health facilities, and countries, and leading to both increase in knowledge in the women, in the patients, and change in practice amongst the healthcare providers. So we've had over 70 healthcare facilities participate in our ECHO sessions since inception, most of them being primary and secondary level facilities. 81% of participants have been from Nigeria. We've also had in attendance participants from Ghana, from Uganda, from the UK, from the US, from Canada, South Africa, to name a few. And we have seen amongst people who have attended the Tele-ECHO sessions, 12% increase in knowledge for pregnant women and nursing mothers and their support givers, and 15% increase in knowledge for healthcare workers. But besides, this was deducted from, the pre-quiz and post-quiz tests. But besides that, we've also seen, evidence of shared and increased knowledge based on just conversations that were happening in the chat box. And as you can see on the top right corner, a picture of our, one of the sessions and the chat room going open there, where you can see people asking questions and getting answers to their questions. Next slide, please. Thank you. So we also saw improved self-efficacy, health and digital literacy amongst a couple of women, 119 of them that were surveyed, among 6,473 women that have been enrolled on the digital platform. So as you can see on the screen, some of the results from this survey, you can see 96% of these women said they were able to manage their health and chronic disease better. 73% of them said they were more comfortable using their phones for their health than before they were registered on the mDoc platform, on the Complete Health platform. 80% of them said they knew that any blood pressure above 140/90 was not normal. 85% of them said they knew that, if they were overweight or they were obese, they were at a higher risk of developing hypertension and diabetes during pregnancy. 93% of them said they knew the benefits of, exercising during pregnancy. 85% of them said, they could define diabetes mellitus as having increased blood sugar, increased sugar or glucose in their blood. Next slide, please. Okay, I'll hand back over to Dr. Okoli. Thank you.
Okay, if Dr. Chibo can unmute himself, he has the next 2 slides to present.
Dr. Chibo, please unmute yourself. Welcome on the call. I hope he's still on the call. Dr. Chibo is a senior associate at HSDF, and he'll be presenting now. Over to you, Dr. Chibo.
I can't, can you hear me?
Yes, we can. Welcome.
All right, thank you very much. Thank you very much, Dr. Okoli. So just like Dr. Okoli presented earlier on, one of our goals or one of our results was that we expected to achieve was to estimate the cost of providing the range of integrated maternal and NCD care in our QOC model. And from the slide you have on, you can see that we try to estimate the cost of the usual care approach, and then also estimate the cost of the integrated approach to delivering care. And the major finding here was that we just had minimal differences between the unit costs of services within the traditional and integrated model. In fact, this is across both states, both FCC and Lagos. And you may be wondering what these costs kind of involved. It entails the cost or what it costs the facilities to provide these services. And it includes the cost of human resources, the cost of drugs and consumables, the cost of administrative care, the maintenance costs, and other fixed costs. It also includes the program costs, including the cost of quality improvement, cost of capacity building, cost of some of the demand side interventions that were introduced in the integrated model of care. And the important thing to note here is that between the usual care approach and the integrated model approach, the cost difference is not much. And that means that The integrated approach essentially involves, just changing how these services are provided. It's not essentially bringing anything new on board. You can see at the primary healthcare level, the cost difference is just minimal, between the traditional model and the integrated model. It's just less than about 1,000 naira. And at the hospital level in FCT, you can see that the cost difference is also very, very minimal. And the reason you even have this cost difference now is that before you set up a system to integrate care or to change the approach to care, there are some things that you need to introduce to prompt the facilities, and that includes capacity building, quality improvement, supportive supervision, and all that. So these are the things responsible for the slight difference you're even seeing in cost. And once these things have been done and the facilities are ready to run with the integrated care approach, you might find out that in future, the cost might even be less because the facilities might have an increased utilization or demand of these services, and they'll be using the same resources to now provide care to more people. So you find out that the unit cost might actually drop in future. So the important thing to take away from this exercise is that the integrated model of care is not necessarily more expensive than the usual care approach. And this is what we have presented in this slide. And then if you look at the next slide, the same thing applies to facilities in Lagos. Next slide, please. So for facilities in Lagos, where we included the private hospitals, you can see that it's the same trend, across board. There's just a minimal difference between the cost of the traditional model and the integrated model. And just like I explained in the other slide, the difference is as a result of the program cost, and it's just very minimal. And it doesn't mean that the integrated model has come with a huge cost implication. Thank you.
Thank you, Dr. Chibu. Dr. Okoli.
Okay, thanks, Dr. Aima. So as you can see, we've just presented the results that you all listening to this presentation have achieved. And it's not a mean feat because you know how we have been bothering you in the facilities, and you have also been committed to actually improve services for women that actually visit your facilities. So we say a very big well done to all of you, 20 healthcare facilities and all the healthcare workers in there. So now we want to just share a bit of how. So how did you do it? How did you do it together with us, to ensure that we achieve these results? So as we've done phase 1, we've done phase 2, you've looked at the model. So now phase 3 is essentially when you started implementing, which was October last year to September this year. But we will go through how even for the phase 1. So next slide, please. So if you recollect, I think it was around March, April, May 2019, when we came round to all your facilities to collect some data, to also talk to women in the community, to do point of care tests with women in the community. This was how you did it. A lot of people some people from the Ministry of Health, but Lagos and FCT also helped us to collect this data. So we used mixed method approach to actually collect the data for the first phase, the prevalence study and the facility readiness. We used the qualitative methods. We did in-depth interviews with key stakeholders. We did focus group discussions with women in the community. We did photo voice with women of reproductive age. Then we also used the quantitative method where we surveyed 649 women of reproductive age from both Lagos and FCT, from those local governments I've talked about and area councils. We also did a survey of 79 healthcare workers, 40 from Lagos, 39 from FCT, within the health facilities that we are supporting. And then, of course, a point of care test of 400 women of reproductive age from that 649. So on the spot, we assessed their BMI, we assessed their blood pressure, we took blood for HB1C, and we took blood for hemoglobin level. And then we also went on to do facility assessment of those 20 health facilities where you people work. I'm sure you remember that period. We used the tool to assess your readiness to provide these services. We looked at 380 charts to see how you document things. and how you ask questions when you see patients. 190 of these were from Lagos, 190 from FCT. We also went into the ANC and observed how you actually did your ANC talks with the women to see where areas that we could improve. And of course, finally, we did this survey where we assessed knowledge and confidence of the healthcare workers to provide services. Next slide. So this is just sharing a few more results from the point of care test that we did, calculating BMI and calculating waist circumference for those that were pre and post-pregnant, not pregnant women. You can see, I don't have to read out the numbers. The numbers are very clear there. They're more than half from both FCT and Lagos, from both local governments and the area councils, were either overweight or obese. And these are people aged between 18 and 49 years old. Okay, so if we move on to the next slide. So we looked at, in general, the survey of the healthcare workers. In summary, people were fairly confident, for screening and counseling for high blood pressure, diabetes mellitus, and anemia, but very, very low confidence for calculating BMI. I would even say that BMI was like absolutely not being done at that stage when we started. And then, of course, moderate to low confidence for managing HTN, DM, anemia, and obesity. And whenever I present this, people will ask me, who did you survey? We surveyed a mixture of more of nurses and midwives, but there was also medical officers that were part of this. I know that nurses do not necessarily manage hypertension and diabetes and anemia, but you do see in some primary healthcare facilities where people actually start off something and then before they then refer to the general hospitals. If we move on to the next slide. So we asked women, the healthcare workers, some questions around common symptoms of PEE, preeclampsia and eclampsia, and you can see that 65% got them correct, so they were about 35% that were still not sure of what it was. We asked for the normal BMI range. That was pretty low in terms of people answering them correctly. We asked questions on a few hypertensive drugs. Which one would you use? Which one was safe in pregnancy if you were actually going to start the treatment of a pregnant woman before you refer? You can see the numbers there. We needed to do some improvements. If we move on to the next slide, then when we reviewed the charts, the patient notes within the health facilities, we reviewed 380 of them. You can see that there was just limited documentation for high hemoglobin, blood pressure, genotype, blood sugar, urinalysis, HIV status. Family history was even like very inconsistent. The personal history, asking women the question. And I'm sure the questions are probably asked, but it's actually documenting them. And then even documenting past history of large babies so you have an idea what that woman had previously. And then, of course, documentation of weight value, BMI classification, and so on and so forth. Next slide. So we also went out and did focus group discussions with women, in both states. And what did the women tell us? They said the reasons that they had poor utilization of health services were because of user fees. That whenever they come, there is one fee here or the other, buy a card, do the blood test, all those sort of things. Buy this drug, buy the other one. And then sometimes poor staff attitudes, and then attitudes and beliefs of themselves. They were women of reproductive age. And then also the long waiting in the facilities. And this can be seen in general hospitals, that it does drive them away from coming to facilities. And then sometimes distance on where they live from the nearest health facility. So we asked them, what do you think? How do we mitigate this? What are your ideas? Then they said, that we should continue training of healthcare workers, especially around the attitudes and so on. And then also to start raising awareness within the community on these NCDs. And then also to get government, that we should get government to provide free health services. But it is very difficult for government to provide free health services. So I guess what we are working towards is the health insurance. If we had health insurance, at least if people paid up front, then they can actually receive services without having to pay at the point of care. and then government to put more money for provision of health services that is nearer to them in the community. So these were what the women said. Okay, so moving on, next slide. Okay, so moving on, this is essentially what the new components that we added based on what people told us and based on the gaps that we identified. So we added things like on-site skills training. We added the ECHO sessions to refresh people. You've had so many topics within this ECHO session to actually enhance what you do. And you also know that during the ECHO session, sometimes you present your case studies that we discussed that helps you in managing your patients. And then we knew that we had to do something about job aids and guidelines. And I believe that as of last week, we've managed to distribute the new guidelines that we have developed and job aids within the services. And then all the gaps, the quality improvement teams, we know we have set them up. You know your quality improvement teams within the 20 facilities. You know the work that you're working towards. You meet monthly. And then, of course, the virtual support of women to improve their self-care, and the Tele-ECHO sessions, even for women during the COVID session, the COVID pandemic period, especially the peak period. And then, of course, we instituted things like peer-to-peer learning between the health facilities. We've had 2 of those. We had one in person in February. We had another one online, I believe it's this August, where you all come in and share what you have been doing. And then we also talk through the achievements and challenges and advice and share all the successes. We also did the costings and the physical space analysis, yes. So next slide. So I'm just going to, because I'm so proud of all the hospitals that are part of this, I'm going to read them out for those that might be online that don't know the hospitals that are part of this. So in the FCT, the state selected hospitals that have been working with since November 2018. So in AMAC, we have Wuse General Hospital, Nyanya General Hospital. We have Primary Healthcare's Gidan Mangaro, Lubwe, and then we have Saffron as the private hospital. For Buhari, we have Buhari General Hospital, Kubwa General Hospital, we have Dutse Alaji PHC, Mpape PHC, and we have Daughters of Charity. And I'm sure all of you are online. Well done to you all. For Lagos, in Alimosho and Ikorodu, we have Alimosho General Hospital, we have Ipaja PHC, we have Akuonjo, we have Rauf Areboshole, and then we have Mobonike Private Hospital. For Ikorodu side, we have Ikorodu GH, Itaelewa, Odonla PHC, Okele to PHC, Oak Private Hospital. Honestly, kudos to you all. You've done very well. You know there are areas for improvement, but as we are scaling up, I'm sure you will do more. If we move on to the next slide. So what have you done? This actually testifies what you have done for the last 1 year. This is just within 1 year, October 2019 to September 2020. You have seen a total of 26,712 women booking for the first time. I'm not talking about attendance of ANC. That is even more. This is just women who booked for ANC across those 20 facilities. We have seen 17,000 of them coming back to give birth within the facilities. And we have seen 13,789 of them coming back to attend a PNC. During that pandemic, peak of the pandemic period, March, April, May, we saw 45% reduction in booking for ANC. We also saw about that same amount of proportion reduction for those attending PNC because we were not sure what to do, where to go. There was even no transport services to be going to the hospitals. And even the healthcare workers were not even able to come to the hospital all the time. People were afraid that they would catch COVID and so on and so forth. But nevertheless, you've done well. We know we need to improve on women coming back for PNC or being checked before they are discharged. And we need to encourage more women to actually come back and deliver within the facilities. But you've done a great job. 58,388 women beneficiaries, within this 1 year across the 20 facilities. And this is just to say that we have trained 450 of you, 225 from Lagos, 225 from FCT, using the training curriculum adapted from the Nigerian Package of Essential Interventions. I thank the facilitators from, I think, almost 8 general hospitals and private that actually helped us with this training in August. And I thank the quality improvement consultants that have actually helped with this as well. If we move on to the next slide. So these are just pictures from the training sessions and people doing, role plays and practicing what to do with their patients. Moving on to the next slide. So we have distributed all these posters for anemia, diabetes, hypertension, and obesity. We've also distributed a desk job aid that is in a flip chart form that you can use in your facility. If you haven't received them, please chat in the chat box and say your facility has not received them. We will get them to you. Okay, next slide. So, during all this, there are challenges. There are challenges that we have to work on. There are challenges that we have also, some hospitals have worked on and improved on. And these include encouraging people to, at least the women doing their first booking, to use the Nigerian PEN guidelines, which is based on FIGO guidelines, to at least do a random blood sugar for the first visit. I know you people do urine dipstick, and then if anybody tests plus sugar, then you go on. But we are encouraging people to do it at least for the first visit, even though it's stipulated it's first visit, second and third trimester. There are issues about having glucometers. There are issues about having strips for that. And then some people do blood tests at every visit. Some people do at first visit, but we're at least encouraging you to do for those booking for the first time. And when we started, there were virtually no measurements of BMI, but that looks like it's something in the past now. It's history now. People have cordoned onto that and are doing that very well. We are still struggling with some facilities not having functional weighing scale, not even having functional blood pressure machine to use. But again, we are following up with the health and the ministries to actually help them, the primary healthcare facilities. And yes, and then there is also still an issue between getting the test results from the lab and then sending that to ANC. We know the particular hospital, so we are working with them to improve on that. Okay, moving on to the next slide. Okay, this is just to, again, to say well done to you all. You all have established quality improvement teams. Especially at the ANC, you all are in a WhatsApp group. One of the hospitals, Nyanya, is saying that they cannot hear anything. I hope you can hear me. Ima, confirm that you can hear me.
Dr. Okoli, loud and clear.
Okay,
our tech person will get across to them now.
Okay, so we have WhatsApp groups where we share messages, where we walk through, and that chat in this particular the graph below shows how many times the quality improvement teams meet every month, or how many of them meet every month. And you can see that actually, apart from that height of pandemic period, March to May, that you guys are doing your best to actually meet everybody, every month to look at your issues. So there are so many things that you have done well. There are so many things that you have done well. Change ideas from different facilities. Things like some facilities marking their ANC case notes for pregnant women who have diagnosed with complications red. So it's easy to identify them. Things like using a BMI app downloaded to actually calculate the BMI in a very easy fashion, rather than using all those formulas. So if you download this BMI app, you're able to do it. Many facilities have done that, including BMI measurements, even in ANC cards. Some facilities have done that. Identifying a staff that is responsible for recording and collating the indicators that we are talking about. Most facilities, in fact, all the facilities, we have a record person that is supporting that. And then conducting weekly audits. Some people do that between the register and the NCD registers. I'm happy to say that going forward, we would actually discard the NCD register that we gave you, because we were using the HMIS 2013 register, did not have the indicators that we wanted. but the 2019 NHMIS register now has most of the things we need. So I am sure that that has actually been shared in most of the facilities that we are working with. Again, if you haven't received it, please chat in the chat box. We will ensure that we get that to you. Then, of course, discussing the monthly ECHO sessions, lessons learned from it, fantastic change ideas coming from there. I was so proud at the last learning review. Some of you had the opportunity to present, and you presented how you have been managing through the COVID-19 pandemic and what changes you have actually made in your facility. And that was really fantastic to see the different innovations that you people are using within your facilities. Quality improvement is about change ideas. Quality improvement is about continuous work, continuous improvement for every patient without letting any patient actually slip by. Okay, let's move on. Move on to the next slide. So these are just success stories from different facilities. I won't go into reading them, they are quite tiny actually, but you know, you've given us success stories time and time again. So we are proud of all of you for what you have changed and what you have learned from this particular project. Moving on to the next slide. Next slide. So this is just one of the photographs we took. This is in Lagos actually, when we had our first learning agenda review meeting where we gave certificates out to motivate people. But learning meetings is a very good place to come and share problems, share achievements, get information from the women enrolled on the Complete Health platform to see what challenges they are having, because it's the same women that you see in your ANCs, so that you can ensure that all the information they are getting are aligned. And you're also hearing from them, because most times when they come to ANC, they don't have that much time to talk to you and share their problem. But on the Complete platform, they actually have that time to talk to their coach and share what the issues are. Okay, moving on to the next slide. So this is just one of our beautiful photographs of one of our beneficiaries who came to speak to all of us in Lagos at the first learning review meeting to recall her journey, both with the Complete platform, health platform, and then also in the health facility that she actually delivered her baby. Okay, next slide. Okay, I will hand back over to Naomi now to go through the next few slides.
Thank you, Dr. Okoli. So we saw that it took a multimodal and integrated approach to improve self-efficacy amongst the women who have been onboarded on the Complete Health platform, and quality of care delivered by healthcare workers. And how we were able to do this was through the sensitization of facilities and of the women themselves. And then we went on to onboard women to the Complete Health platform. And as soon as they're onboarded on the platform, as soon as they're registered, they're immediately assigned to a health coach and introduced to our multidisciplinary team. And then they're added to relevant support groups. And on these platforms, they are able to receive health education, have access to answering of their questions, and peer support from their peers who also ask questions or give them answers and share their experiences with them. And in cases of women who are under our priority subgroups, such as women who are over 36 weeks with or without chronic diseases, in the first 24 hours where after they onboard, they receive a coaching call, check-in call from their health coach, and they continue to get follow-up calls, and not just from their coaches. We've seen that this has led to women with healthier and happier life, and as well as them having healthier babies as well. So some of the other things that they have access to is tracking their health indices on Complete Health, tracking their BPs, their blood sugar, their weight, and all that, and as well as having personalized action plans that are created by their health coach. Another thing is, the Tele-ECHO sessions, such as this one, for healthcare workers. Healthcare workers have access to the Tele-ECHO sessions where they're able to learn more about, topics that are important, or topics that, are very significant and relevant at that time, as well as the women themselves. And then we were able to link and refer these women during when they have health emergencies to their nearest primary and primary healthcare facilities. So again, we want to thank the facilities for always swinging into action every time we've referred women to them. Next slide, please. Any next slide.
Hello, is Dr. Aima still there? Well, it looks like you're having slight internet issues. Okay. Dr. Naomi, are you still there? You're muted.
Hello, can you hear me now?
Very well, yes.
Sorry about that. I lost my internet for a bit. So despite the educational level and high smartphone penetration amongst the women who were enrolled, low health and digital literacy levels, we saw that required significant investment from our coaches to help build these women's capabilities. Since 30th of September this year, we've enrolled over 6,400 women, and amongst these women, the average age of these women has been 30 years, and 97% of them have been women with secondary school certification and above. 79% of these women were women who own smartphones, and the rest of the women who didn't own smartphone who were touching base with them, supporting them via SMS and via voice calls. Next slide. Okay, so what we noticed that the women were very, very engaged with coaches who were providing them self-care and clinical touch points for themselves and their babies. So we're getting questions, from questions about exclusive breastfeeding and how to ensure that their babies were latching well, to, women asking questions about how to regulate their blood pressure when they're stressed, and a lot of other questions that were, concerning for the women. We've had over 81,000 messages that have been sent to the women, and over 8.8 million number of total interactions have been made between the coaches and the women. So our coaches have logged over 5,700 calls, and of these calls have been made to over 3,400 members. And most of these calls, 30% of these calls have been made after hours, between the hours of between 5 p.m. and 8 a.m. in the mornings, and again over the weekends. The average duration of these calls have been 9 minutes, 22 seconds, and each of these women have received at least 1 to 20 calls on the average. Next slide, please. So during the peak periods of COVID-19, we saw that the importance of virtual support for for these women, as we saw an increase in undiagnosed hypertension. Like Dr. Okoli mentioned earlier, a lot of the women were worried about even going to the health facilities because they were scared of contracting the virus. And again, there was also a general decline in access to essential health services like antenatal, postnatal clinics as well. So this resulted in a lot of undetected changes in health conditions. And if you look to my right here, you can see a chart showing a chart for one of our members who was onboarded around February this year, and her systolic blood pressure on onboarding was 134, and diastolic. Can you hear me? Hello?
Yes, Dr. Naomi, we can hear you.
Okay, thank you. Her systolic blood pressure on onboarding was 134, and the diastolic was 77. And then during the, because she wasn't able to access the facilities during the peak period of COVID, her blood pressure as at June was 176 over 116. And we can see it kept going on until we were able to intervene. And, at the end of, by 25th of June, you can see the systolic blood pressure was able to come down to 126 to over 79. Next slide, please. Previous slide, please. Thank you. Our multifaceted COVID-19 response involved expanding the breadth and depth of our services. So we expanded from digital self-care reminders and nudges to urgent and emergent care for our members. And at the core, listening to the voices of the women and the healthcare providers as well. So what we did was we prioritized high-risk pregnancies and ensured that we're providing more frequent touch points and interaction to women, that were, of high-risk pregnancies, women that had high-risk pregnancies. And then we provided virtual antenatal and postnatal care and newborn care touch points as well. We provided mental health support for those who were, dealing with anxiety, depression, given the situation with the pandemic at that time. And then we increased the frequency of our Tele-ECHO sessions for both the healthcare workers and the women, and ensured that we're focusing on COVID-19 related topics. And then, sorry, 1 minute. And then we also provided, PPE for new mothers who were, at that time in the facilities, some of the facilities, or most of the facilities actually. We provided PPE delivery kits to them. We distributed COVID-19 infographics and materials, and also using our Navi Health platform, we provided patient navigation services. Again, we also launched the COVID-19 and pregnancy support messaging groups for the women, and ensure that we're now holding weekly Tele-ECHO sessions for our members. Next slide, please. So on the screen, you can see some of the testimonials we've had from our members, who are just thanking mDoc and thanking their health coaches for supporting them through, different phases of their pregnancies till they delivered successfully. Next slide, please. Thank you. This is another testimonial for another story of one of our members, a 28-year-old woman who was diagnosed with pregnancy-induced hypertension, and her health coach was able to support her through behavioral changes, such as tracking her blood pressure and ensuring that she reported to the facility anytime she had an emergency or a very high reading, and then also to increase her exercise and reduce her intake of salt. Even when she was worried about, when her doctor told her she had to be induced, she was very worried. Her family members were worried. The coach stepped in and played a vital advocacy role, to reassure the family members and reassure her as well. And we're happy to say she delivered a healthy baby, and she has continued to receive breastfeeding and newborn care support from us. Next slide, please. And I'll hand back over to Dr. Okoli. Thank you.
Okay, if we can have the next slide. Is it up? I can't see it from my end.
Okay, it's up.
The challenge is it's up. Yes.
It's up.
Yes, you can't see it.
No, I can't see it from my end. Okay, but yeah, let me.
And we are resharing it again, so hopefully it becomes clearer now.
Okay,
Yes.
but I have the slide in front of me anyway, so I can keep going until you share. So some of the challenges that we've had, like I mentioned before, is targeted, some of the targeted quality care indicators, especially relating to these NCDs that we are looking at, and not in the HMIS 2013 register. So they are not in the DHIS2. So, but luckily the 2019 register, they have most of it. And so we have actually begun to distribute the registers within all the 20 facilities that we are supporting. And please, if you haven't received them, do say on the chat box so we can get them to you. So at least we are not having a separate register to start collecting data. We're using what the national, the government has actually prescribed. And of course, you can see that when we started with a very low baseline of quality of screening. But things have improved, but we need to still improve in some areas. Limited guidelines, luckily we have designed and developed guidelines, which we have shared now. And then of course the weak linkages between ANC and the laboratory, which we are going to work on as we scale up. Same with referrals, we're going to also keep working on referrals. And of course the COVID pandemic was a significant challenge. We've heard about it here, but all of you have managed to try and get around it. So we're still living with COVID. So we'll just keep going and keep finding ways to protect ourselves and protect our patients. And of course, when we were doing the costings exercise, there was limited data from the ministries to do that. So this is, we want to, despite all these challenges, you guys have done a great job. I don't know, because I can't see the slides. I suppose the next slide is on just probably thanking people, thanking the ministry, Lagos State, thanking the Primary Healthcare Board in both states, the Hospital Management Board, the Health Service Commission, FCT itself, and then of course, thanking the 20 health facilities that you have done all this job. We just felt that we needed to do a session where you all will be available to hear what you have actually achieved, so that can actually make you want to achieve more for your patients as we move along. And who else should I thank? Thanking everybody, thanking mDoc, HSDF, and JPIGO staff and the quality improvement consultants as well.